This is the Exam 3, Everything You Need to Know for Pathology, lecture part 1. Starting out here, it says we need to know everything about disseminated intravascular coagulation, commonly DIC up here. That's how it's often shown. So basically what's happening with disseminated intravascular coagulation is that it's going to be triggered by some kind of malignancy. The one they highlighted was acute promyelolytic anemia. Also, if you give somebody some the wrong kind of blood, like the ABO blood type problem, or if somebody has sepsis or trauma or something like that, then this can lead to the widespread microfibrin thrombi. Made a special note here: DIC, disseminated intravascular coagulation, is not a disease. It is like a it's like a secondary disorder. It's like something associated with it. It's not a disease in and of itself. So essentially what happens here is when a person has these widespread microfibrin thrombi, essentially what it is there's lots and lots of tiny little places where they're starting to form these microclots. You can't see them with your naked eye, but they're very obvious under a microscope. And these are happening all over the body. And it's going to lead to a couple of different things. For one, the plasmin can be activated, and you'll start to have this massive fibrinolysis going on. In other words, the fibrin that in these little clots is going to start to be broken down. Well, that's using up all of your fibrin in your body, which is necessary in order to make clots. And if that happens, then you're going to get a bleeding disorder. So the plasmin activation, fibrinolysis, that's one thing that can happen. Okay. Another thing that can happen is you can have this thing called consumption coagulopathy. Basically, it's like all of the clotting factors in your body are going towards a wound that isn't there. And essentially what's going to happen from that is that you're going to use up all of your clotting factors. And if you use up all of your clotting factors, then that's going to lead to, again, bleeding disorders. So this plasmin fibrinolysis and the consumption coagulopathy both lead to bleeding disorders. The other thing that can happen is you can get ischemia. So these little tiny microfibrin thrombi, they can grow and they can spread all over your body, and they get to places where they obstruct blood vessels. And if they do that, then they're going to cause ischemia in areas which can lead to tissue damage. So those are the three things that can happen with these widespread microfibrin thrombi, or with disseminated intravascular coagulation. So acutely, what you'll see if you want to find out what this person has and you start seeing these symptoms is you're going to see hypofibrinogenemia. Okay, so basically low fibrinogenemia. So that's going to be acutely low. The other thing is going to be low acutely. They're going to have low thrombocytopenia as well. Okay, excuse me, not low thrombocytopenia. So acutely, you're going to see thrombocytopenia. I apologize. Next, you're also going to see a high PT and a high PTT. So what that is basically when you are, goodness, not the name escaped me. Look up PT and PTT. Oh, here it is. It's Prothrombin Time and activated partial thromboplastin time. Essentially, it's in the clotting cascade. There is, when it goes to like the clotting factor 10, and then it goes from 10 to 2, it changes prothrombin into thrombin, and then thrombin ends up being the thing that breaks up the fibrin. So that is basically measuring how long it takes for that to start occurring. And so if a person has a really excuse me, when I say low, I should have said high. It means that the time, it takes a long time for that to occur. So it's a high PT and high PTT. Goodness. So basically, it's the time for those steps to occur takes a long time because they're all used up, which totally makes sense. You've used them all up in these things. The other thing is that there's going to be high D dimers, and also something called microangiopathic hemolytic anemia, the acronym MAHA, microangiopathic hemolytic anemia. And basically what this is you see these cells called schistocytes or helmet cells, and basically what it is a red blood cell that's been basically like destroyed, or kind of the bottom like cut off of it in the spleen or something like that. And so it looks like sometimes like a little helmet, kind of. So that's what they've called it. Okay, so that is disseminated intravascular coagulation. Next, what we have is we need to know everything about heparin-induced thrombocytopenia, shown here as HIT. Okay, so first of all, with heparin-induced thrombocytopenia, you have two kinds. You have type 1 and you have type 2. Type 1 is not associated with your immune system. It happens rapidly, it's mild, and if the person has that, you just continue giving them heparin because it's not that big of a deal. But if they have type 2 heparin-induced thrombocytopenia, this is something where, well, first of all, it's going to be delayed. The other one type 1 happens pretty fast, you know. Type 2, though, is going to be like maybe after 4 to 20 days, usually 10 days. It's going to be really serious. It has to do with your immune system, and which means you're going to be developing antibodies for this, which I'll explain in a minute. And a lot of times this will happen in people that have had previous ortho surgery. And it's very serious. And if that happens, type 2 happens, you need to stop giving them heparin immediately because they could die from this. So some of the big risk factors here is if you give somebody unfractioned heparin, I guess that's heparin that's too big of pieces or something, I'm not sure exactly. Also, post-operative thrombophilaxis or being a female increases your risk of heparin-induced thrombocytopenia. So basically what's happening with this is you have on your platelet something called platelet factor 4. And platelet factor 4, apparently, if my understanding is correctly, normally it'll bind to heparin, and then and this is the useful thing with heparin, is that the heparin kind of binds to it and it activates the platelet factor 4. And that's good. Okay, so now the person's not going to have these clots or whatever. But the problem, though, is that sometimes when heparin and platelet factor 4 bind together, an antibody will neatly bind to them, and if you have an antibody binding to this combo of heparin and platelet factor 4, well, what's going to happen is now it's going to the antibody, which they call it an anti-platelet factor 4 and heparin antibody, is going to want to cause macrophages to eat that. So macrophages are not going to eat this. So as this red blood cell as this platelet with heparin and platelet factor 4 and an antibody goes to the spleen, your spleen is going to destroy them. And that's going to lead to thrombocytopenia. And also what could happen is as this antibody is bound to platelet factor 4 and heparin on the platelet, is that it could cause platelet activation. And if platelet activation comes from this, then the person could have a thrombosis. They could get a big thrombus, okay? Those are two bad things, thrombocytopenia or thrombosis, two bad things that could happen. So that's everything with kind of the mechanism involved, but if you want to see the symptoms, what is a person going to look like who has this? First of all, they're going to have skin lesions at the site, subcutaneously, where they're getting heparin. There could be a systemic reaction if they've been given the heparin via IV, which means like chills, the kind of things you see with systemic. They may have hemorrhages, myocardial infarction. They could have, forgetting what the acronym meant. PAT, okay. They could have a pulmonary embolism. Hold on, let me find out what that stands for. Okay, maybe I'll just have to let it go. Symptom, there it is, symptoms. So they're going to have, here it is, peripheral arterial thrombosis. Okay, that's what PAT is. So they could have peripheral arterial thrombosis. They could have, later on, they could have disseminated intravascular coagulation, which we're talking about over here. They can have skin necrosis. This typically will occur, somewhere between 4 to 20 days, or usually the average of 10 days. So how would you get a for sure diagnosis? Well, if a person gets thrombocytopenia within 5 days of giving heparin, well, that's a big clue. Especially if you stop giving the heparin and then they start getting lots of platelets again, that's a big indicator. But typically what you're going to see in a person with this is they're going to have a very low platelet count, somewhere like below 150,000. And you're going to find that they have a high PT and a high PTT as well. So that takes a while for the prothrombin to get activated. And you're going to see fragmented red blood cells. And also, you're going to find, if you were to do an ELISA test, which is a way of seeing what kind of people, what they have antibodies for, you're going to see that there are antibodies to the heparin platelet factor 4. So That's a big one right there. Okay, so next here is we have to know everything about Antiphospholipid Syndrome, shown here as APS. First of all, again, there is primary and there is secondary, and we can't really tell the difference between primary and secondary as far as what they do, but we understand that primary is not involving the immune system. It could be drugs, it could be something else, and secondary does involve the immune system. This is where a person essentially has antibodies for phospholipids. Particularly, they mention beta-2 glycoprotein 1. So with what essentially happens is that the phospholipids bind to the antibodies, and this causes hypercoagulation. Okay, so that means they form a lot of coagulation in their bloodstream, and this is an acquired or secondary situation here. So a person that gets APS or antiphospholipid syndrome is at increased risk for repeated miscarriages, increased risk for thrombosis, increased risk for cardiac valve vegetations, and increased risk for thrombocytopenia. So when you take someone's blood, this might be a way to detect whether or not this is exactly what the problem is. Essentially what you do is you'll take their blood, their serum, and in vitro, which is like in a test tube, this is not in the body. Well, in vitro there's no endothelial cells, and you'll find that the blood is hypocoagulative. Why? Because they don't have any endothelial cells. It's the endothelial cells that need to receive those phospholipids to be triggered. So if you check it in vitro, hypocoagulative blood. But when you put it in vivo, you're going to find that because there are, in vivo means in the body, live, in the body there are endothelial cells, and so they will have hypercoagulative blood. That's if I understand that correctly. I apologize if I made any mistakes. Next, you'll also see with APS something that's kind of a strange anomaly. You'll get a false syphilis test. So you'll test them for syphilis, and you'll find out, it'll say that they have syphilis, but they don't have syphilis. And the reason for this is because the antibodies are binding to cardiolipin, which is a phospholipid. And so it looks like, oh wow, they must have syphilis, but no, in fact they have APS. And a long time ago this used to be called lupus anticoagulant syndrome. And that is the first part of all you need to know for the third pathology exam.